So before we get started, can you guys hear me okay? I think I'll do this from the podium. Before we get started, I wanted to first say hello. My name's Anna McCollister. Trying to figure out the technology here. But I wanted to start with a little bit of context for what it is we're going to be discussing. Let me just work with the slides. Okay. I wanted to start out with a little bit of context for what it is we're going to be talking about today. And over the years, I've done a lot of presentations with different companies. And when I first got started, I was frustrated a lot in speaking to corporate audiences because there seemed to be an inability to really understand why asking a patient to do, I was doing a lot of work in medical devices at the time, or advocacy in medical devices, and like companies, people who worked for companies had a hard time really understanding why asking a patient to do a 20-minute data download once a week was a big deal. And as a patient, it really frustrated me, and I had a hard time getting through them. So I was asked to speak to the board of directors and executive team for a major... This one isn't working? Okay, I will stand over here. How's that? Just one or the other. One or the other. All right, got it. So I was speaking to the board of directors and executive team for one of the big major diagnostic companies. And ahead of time, I spoke to the head of one of the members of the board of directors, who with great empathy said to me, it was really how he knew diabetes was difficult because he had seen people prick their fingers to get their blood glucose levels, and he couldn't imagine life without living that way. At which point I said, that's what you think is the difficult thing about living with diabetes? So after that, in preparation for this presentation, I put together this slide, which I've used many times over the years to kind of give a sense of what it is that patients actually live with. So when I was first diagnosed with diabetes, I had no idea what was happening, what it meant, but within short order, I discovered that there were 5 core pillars of my diabetes treatment, which are represented by these circles here. Seems relatively straightforward, things that most people need to deal with on a regular basis in managing their life with diabetes. But the reality is a little bit more difficult. I'm going to build this out gradually. So first, we're starting with lifestyle. So what exactly does that mean? You have to eat right, sleep well, manage your stress, take lots of supplements, or at least I do, for specific reasons. You need to exercise, but it's not just exercise. You have to do strength training, cardio, yoga, etc. So that's just lifestyle. That's the basics. How many people in this room actually can do that on a daily basis the way that you're supposed to? Right, but that's the thing that people with diabetes get judged for all the time. Next, you move into doctors. This slide's a little bit updated. I currently have 16 different physicians. So the last time I bothered to count, that was 63 different doctor's appointments in 1 year. So that's traveling to the doctor's appointment, sitting through the doctor's appointment, all of the issues with scheduling, actually having the appointment, doing the follow-up, the blood work in advance, etc. Times 63. So then you get to medications. This slide, again, is a little outdated. It's been a bit of an eventful year, and I haven't updated it since earlier in the year. I'm currently at 21 different medications. Not all of those are daily, but enough of them are. And many of them require prior authorizations. I am the one that's responsible for managing all of it. Allegedly, my physicians do that, but the reality is that they don't. I have to stay on top of all of the refills, making sure the pharmacy has refills, making sure the physician calls them in, the physician's assistant calls them in, managing this whole process, making sure the lab work that's required for prior authorization is drawn, gets from the physician's office to the insurance company, the insurance company to the pharmacy. All of that is on me. And again, I take 21. Next, you get into lab works. Get lab done a minimum every 3 months. There are about 117 different things that are measured every month. These are the ones that I really focus on specifically to track my kidney disease, which are important for me to understand. And then you get into medical devices. And again, I've actually added one critical one at this point over the past year. It's been a challenging year. So I'm currently using about 11 different devices. 5 of these are with me anytime I leave my house, 4 are attached to me 24/7. Precisely 2 of them are actually connected from a data perspective or from a clinical perspective. That's my insulin pump and my continuous glucose monitor. And the only reason that those 2 connect is because the patient hacker movement that I helped start with some friends a few years ago hacked them and connected them. So when we talk about patients and the life that patients live, this is what we're talking about. So any additional thing that industry or a doctor or an insurance company asks me to do is added on top of this workload. So it really does get to be a big deal when you add one more thing and one more thing. And what may seem like only 5 minutes or 10 minutes or 20 minutes of additional work for you is added to this broader milieu of activity and workload. And if one of these things goes off, it can throw off your afternoon. If more than one of these things go off, it can get you into medical issues quickly that require you to stop everything else in your life and to make things work. And if you're working, everything has to stand still. If you're taking care of your family, everything has to take a second back seat if your hope is to actually stay on track and to keep your health managed. So this is the every patient. And people like to tell me that I'm an outlier, and I would say the only reason that I consider myself an outlier is the fact that I'm standing on this stage. My mother just passed away, and I asked my siblings to keep all of her medications for me because I wanted to have them as a visual image of what she was dealing with. I had 3 large shopping bags full of medications of things that my mother was dealing with in the final times of her life. And that is not unusual. So when we think about interoperability and making things easier, this is what we're dealing with. So when something happens that isn't what you are expecting, it really can be a big deal. And recently, as we were working through the activities of the work group, I had a situation of where things became a very big deal very quickly. As you can see, I'm a little bit different. I'm a bit of an outlier. I'm a member of the Sequoia Project Board. I'm a member of the Health IT Advisory Committee. I've done a lot of different things in patient advocacy over the years, as a volunteer mostly, helped start a patient hacker movement. I am the epitome of the empowered patient who's able to advocate for myself to get what I need. However, recently I went through a pretty substantial and frightening health issue. For a variety of reasons, my vision started decreasing. And I was told by the doctor that I had a very urgent situation that needed to be attended to. It happened in the midst of a very difficult family issue. As I mentioned, my mother just recently passed away. A lot of different things were going on, and I desperately needed to get access to my images for my eyes, images that had been taken once a month for more than a year that showed the progression of my disease over time that were critical for me to get a second opinion at one of the top retinal specialists in the world. So I managed to get the appointment, needed to get the images, and couldn't. What I experienced when I tried to get access to the images, which were sitting in a server about 10 minutes away from where I live, is they sent me directly to medical records. Now, I knew that the images were sitting in about a 10-minute Uber ride from where I live. They sent me to medical records, which was about an hour outside of DC in a suburb that I'd never been to, and told me that I needed to write a check, send the check via mail, or I could hand deliver it if I wanted to. After the check cleared, they would have 30 days to get me my data. And I had the appointment on a Monday, like the following Monday. It was incredibly frustrating because I was told by the doctor who had been treating me at this place that this was urgent. It needed immediate attention. I'd managed to have been able to get into this top ophthalmologist, And they were keeping me from getting the data that I needed, that ophthalmologist needed, to be able to treat me appropriately and do the right thing. So it happened to coincide with an in-person Health IT Advisory Committee meeting. So as I'm sitting there, confronting the fact that I can't see all that well, dealing with the fact that my mother was in the process of dying, I'm surrounded by, Mickey Tripathi was there, Steve Posnack was there, Devin McGraw was 2 people over. I was surrounded by people who knew the law, who actually wrote the law around information blocking, around getting data access, who'd done all of this work from a policy perspective to make it happen. I knew the law. I knew what the issues were. But because I was in a moment of stress, I wasn't able to think through exactly what I needed to do to be able to get access to my data. And I'm trying to have this conversation via email with the ophthalmologist as I'm sitting in this high-tech meeting. Later that day, I had a little bit more clarity. Unfortunately, I have Devin McGraw's personal text number, so we were texting, and she reminded me to take a look at the information blocking rules, at which point I did, and was able to use ChatGPT-4 to find the exact part of the Code of Federal Regulations, pulled the exact language from the information blocking rule, and sent a letter to medical records and the office manager. And that got them moving. I informed them that if I didn't get my images in time, that I would file a complaint for information blocking because they were not giving me access to the data that I needed, that it was in an electronic format in a timely manner. So this is the stuff that we have to work on to make better. If it's that difficult for somebody like me in this sort of a situation, what's it like for the average person? The reality is that they don't get access to the data. So they don't get the medical treatment they need in the way that they need it. And this is the work that we're doing in the consumer engagement work group with Sequoia. This is the kind of stuff that we're focusing on addressing. And we're hoping to overcome some of the barriers and to make it possible for you, for those of you in this room, and for people like you that aren't members of the Sequoia project, to be able to develop the materials to be able to help people who are faced with an urgent situation so that they can get the data they need to get the treatment they need in a timely manner. So with that very long context, I'd like to ask my panelists to introduce themselves. We have a great panel here representing people who participate in various aspects of the work that Sequoia Project is involved with or is doing through our work group. So Holly, would you like to go first?
Thank you, Anna. Thank you for sharing that story. I think I'd like to start by saying I don't think there's anything more important than engaging patients and having them be defining their care team and being the most significant member of that team. So that being said, this is a very important issue for me and what you just shared. I am the Chief Medical Officer for MedAllies. I'm an internist, and we are one of the initial QHINs. We also are a network company, and so have a care quality and direct network as well. The company is physician-led, and our CEO is co-chair of the PTAG.
My name is Cathriona Dempsey, and I work as a manager in regulatory informatics at Stanford Healthcare. And Mickey brought me back to my first days at Stanford with his storyline, starting with Meaningful Use 1, Meaningful Use 2, because that is the area that I work in. And that has brought me forth in, because a lot of the work that's regulatorily required is in those objectives and measures specific towards patient access. So that's my brief background for now, and I'll hand it over.
So my name is Josh Mast, and I'm with Oracle Health. So my part within Sequoia is multiple levels. So I'm really big into all of the work that the Sequoia project does. I'm on the board, I'm on the evaluation, or the steering committee and the evaluation team. I'm co-chair of the information sharing work group, and I also participate in other groups such as the consumer engagement work group, where we get a chance to hear from Anna and others on the importance of a lot of the patient engagement and consumer engagement aspects. And so very excited to be here and part of this.
So I'd like to go to each of you and ask you, within the context of the work that you do, that's part of the activities of the Sequoia group, I'd love to really have a sense, and for you to tell us and to tell the audience, what is it that what does the work group do that's really designed to decrease the burden on patients? And how does the work of the work group and the QHIN, how is that going to, or how is that hoping to decrease the burden that we saw in my slides as it relates to patients? Josh, do you want to go first?
Sure, yeah. So I've been involved in the information sharing work group since its inception in 2019, I believe is the year. So we've been tracking on the information sharing, information blocking regulations. We've been working diligently to put out collateral. So a few years ago, we put out a round of collateral that included good practices, and similar to best practices, but good practices. And we also broke down EHI, electronic health information, in a couple of different ways. We tried to provide kind of a minimum level of what could be considered EHI across a spectrum. And we tried to outline how to operationalize the concept of EHI. And then just recently, this month, I wrote this down to try and make sure that I got this exactly right. We released another set of collateral. So we released an information sharing toolkit that includes information sharing compliance project tool, an information sharing policy, and information blocking rule workflows. So all of that will be covered separately in a webinar on January 9th. So I'm just going to plug that real quick if you're interested in learning more on that. But this last year is probably the least amount of effort that I've put into the information sharing work group. Not that the collateral isn't great, it is, but a lot of the effort was actually driven by Mel Solis, who I believe is here, and Matt Becker, who were leading some of these groups to put together the collateral. I believe the workflow itself actually came initially from Epic, and then we've continued to work on it. So it's a group that has been meeting for several years that is very dedicated towards trying to create an understanding of information sharing and compliance with information blocking regulations. And how does that play into consumer engagement is the topic of how to engage consumers, how to present them the information in the way that they can best make use of it, or that it makes sense to them. How can we ensure efficient access to information? These types of questions are constantly coming up in the work group, and it's something that we've kind of long debated and discussed, and we knew the consumer engagement work group was going to be starting. So I think, and I don't want to head off in any of your future questions, but as the consumer engagement work group gets into some of the best practices in collateral creation, we'd probably look to try and work with you or incorporate some of those pieces as well as we continue to move forward and the information sharing regulations continue to evolve.
Okay.
And as I mentioned, I work in regulatory at Stanford Healthcare. So, and a lot of our the objectives that I work upon have got to do with electronic sharing of information and patient access. There is one specific measure called patient access, and that one is a numerator, denominator, and percentage that every organization, to meet meaningful use, which was prior to changing to the merit incentive payment system and promoting interoperability on the hospital side. So when I sat in the audience last year and I listened to Anna and her group sit up here and the struggles that Anna was having even last year, I thought, oh my goodness, how could this be happening? We have regulatory requirements that organizations need to meet. We have information blocking that Mickey talked about earlier on. And it's like, why? I did not honestly understand why Anna was having such a struggle. So immediately after that meeting, I introduced myself to Anna and to Brenda, and I said, could I be a part of that group? Because I wanted to make it better. It is a regulatory requirement that patients do get access to their health records. And the Sequoia, our group, started, I think we have 8 meetings to date, and we started off with 4 pillars. They were patient access, team access, usefulness, and education. And Anna and Brian and the team, what they did at the initial meetings was they brought on special speakers. We had a number of speakers come on, talk us. Mickey talked to us about TEFCA and patient access. We had Epic came and talked to us about the TEFCA and the IAS project they're working on. And this really gave us a great groundwork of what is out there, and then so that we could work upon that to see, what can we do as a group. Most recently, we did an audit within our group, and the audit was a structured questions for the work group to go out and find out about, what is on the, what are organizations sharing to date, what's on their organization page, or what is in their portal. And of 23 respondents, 13 found that it was very difficult to actually find the information about what is, how do I get data access, what is available to me, to a patient on either the organization web page or their portal. So after we gathered all of that as a group, we've now come to what our tactical plan is. And our tactical plan is that we're going to create a toolkit, best practice. We're going to create a industry pledge, and we're also hoping to get a policy change and make maybe a regulatory requirement that the organization do share for their patients on their homepage. What exactly how to get access to their medical records, what is their a safeguard to their privacy, for example. So that is a summary of what we've worked on today as a group, and I look forward to continue to work with everybody in the group towards those tactical plans that we have in place.
Thank you. And Holly, I know you're not really with...
I wanted to bring up that I've been an active member of the Sequoia Data Usability Workgroup since inception on behalf of MedAllies, and kudos to Didi and her 2 clinical co-chairs who do an excellent job leading that. The group, so imagine a skein of yarn that several kittens have been playing with for an hour or so. That's what people experience as the data that becomes available through interoperability. So this work group is really trying very hard to make that, figure out what the pain points are in terms of the recipient of that data and solve the problem so that it becomes much more usable data. Clearly, this is going to have a huge impact on IAS when individuals access their data. Is it going to be comprehensible? I hope one day they'll also have the ability to correct the data or amend data, but for now, I think making data understandable is critical. The group publishes implementation guides, and we're on version 2, that are incremental steps in order to build an ability to follow that guide and make data more usable. I will say that as our QHIN, MedAllies plans to build that to make available to our customers, to make the data more accessible and usable. Therefore, we're part of the Taking Root movement.
No, that's good, and thank you for mentioning that. He's done such great work for so many years, and it's critical. I mean, it's, you know, I downloaded my data through my portal at Georgetown, and like that stuff's a mess. I mean, it's like what I can't imagine what a doctor receiving it the other end of it would look like. I mean, it's just like pages, hundreds of pages of stuff that's like repetitive, that frankly isn't going to add any value to any kind of treatment decisions. My hope is that maybe AI can help clean some of it up until we get fire moving on all of the different, you know, in a much more robust kind of way. But data usability, I mean, who cares if you get access to the data if it isn't usable? So the work that the data usability team does is absolutely critical. As a patient, I need for that to be useful. So, which is one of the reasons why we have usability and usefulness as one of the 4 core pillars that we're focused on for patient need in the consumer engagement work group. Next, Josh, I'd love to ask you a little bit more. We're kind of just getting started with the consumer engagement work group in terms of producing stuff. We're in the early stages of that, but the information sharing work group's been around for a while. You and I know Chantal's done a great job of leading that, along with all of the many members of the committee, have put together so much great material and resources over the years. What would you say are the challenges in getting that kind of information out to fellow members of the Sequoia project, getting the materials and the great work that you've done actually utilized and incorporated into the work streams of various providers and organizations and EHR systems? You know, what are those obstacles that are getting in the way of these organizations providing consumers with the data that they need, whether it's in a time of urgency or when, you know, dealing with a chronic disease on a regular, ongoing basis?
Yeah, so before I jump into that, I've been kind of bursting at the seams not to jump in because I completely forgot to mention Chantal and all of the team at the Sequoia project that basically carries all of the work that we do for the information sharing work group. I mean, without them, we really wouldn't have the collateral that we have. So I'm sorry that I did not include you the first time around.
And Chantal is Chantal Borzala, who's here somewhere. I can't see, but she's done incredible work. So.
Yes. And she's now, I believe, an actual employee of the Sequoia project, so we can hopefully take even more of her time. So I think that's a great question. We've been trying to figure that out, right? Because a lot of what we do, the collateral we released a couple of years ago, as well as this collateral, the webinar, it's all free. You know, a lot of what we're trying to do is to provide some basic guidelines, some education, because there is still a lack of knowledge and misunderstanding when it comes to information sharing, information blocking. You know, your case is a great example, the story that you walked through, right? That there was kind of a lack of knowledge of the need to provide the information sooner than the HIPAA 30 days. You can't just wait for that 30-day time frame. You really need to look for efficiencies in how to make this information available as soon as you can. So
yeah, I can see that like the office manager and like the medical records person didn't seem to be sociopaths. They'd just never heard of information blocking.
Right.
Literally. That was the first that they had heard of it was when I emailed them.
Right, and it's a challenge because it impacts so many providers, and so in some ways it's easy to hit some of the standard groups that you tend to see on a frequent basis, a lot of hospitals, larger organizations, and even some primary care providers. But as you start to extend out into some of these other provider care areas, it's even harder to reach them or to get them on the same level, right? Because they're not always fully connected in with an HIE or with a portal or with APIs. And so trying to get access and to level set there becomes a challenge. And so I think that's something that we're looking at for information sharing. I don't know that we have a great answer. The evaluation group is also looking at that. How can we take the work that's being done across all of these work groups and really try and promote it and get it out there and monitor how many people are using it and broaden the access. Because I think all of the groups do really great work but trying to determine how best to get it in the hands of the people that really need it, that aren't already aware of it, they're not already members. How do we close that gap? And I don't have an exact answer. I wish I did, because it would be great if we could just reach out and hand it to all of these people in need.
I'd like to share an anecdote that's kind of the opposite of what you experienced, Anna.
That's
I
good.
recently had some tests done, and I have my care all done at the Cleveland Clinic. And as I was having my test done, the physician said, "Well, I will contact you with the results." And I said, "That's information blocking." And she knew nothing about it. But then the minute the results were ready, I got them because the system, through the portal, because the system had been configured for me to get my results when they were done.
Yep.
But the providers knew nothing about it.
Yeah.
Well, no, I will say that I remember when that did not used to be the case. I mean, I remember calling repeatedly over and over again, trying to get access to my kidney values, and the doctor just didn't even bother returning my phone call. I since long ago got a different nephrologist, but that is a testament to the work of ONC. I mean, it's been a long time ago. It was during the Obama administration, in really pushing to get lab values available to consumers, and to get rid of the rule, the requirement at that point to have physicians review them before giving them to consumers. And there's currently a push to change that, which I think would be a really, really bad idea. We need to give patients direct access to the results when they come.
We talked about that, and the fact that it's a little bit patronizing to assume that you have to have a patient say, "No, I don't want to get my results," because all they need to do is not look at them.
Yeah, it's more than a little bit, but that's my personal perspective. Yeah,
Just a quick note on that. So I had a primary care provider just 2 years ago tell me that they could not communicate certain information with me via secure messaging because of HIPAA.
Oh my God,
No.
I love those. Yeah.
So, I mean, that's been out for 20 years, and we're still, as the last panel outlined, still trying to come to consensus on pieces of that.
And Cathriona, as we're just getting started with the consumer engagement work group work stream, we think about this, we think about the challenges that we're facing. What do you think, what are the challenges that you've seen as a co-chair in getting the information we need to really figure out and address these challenges for consumers? So,
I think that we have, as I mentioned earlier on, we've got our tactical plan is a best practice toolkit, industry pledge. And the one I will lean on would be to request a policy change. Because I think even for the meaningful use world that we lived in for many years, it was regulatory required that the organizations, and the information blocking rule that came out as well, it was required that we share our lab results, our imaging results within a timely manner, it was worded. That pushed out the results for your example that you gave, Holly. I do think that in order for us to educate the patients, we do need to have somewhere in the regulatory requirements. Let it be. My thought process would be, as I mentioned earlier, there is a provider to patient exchange objective within the promoting interoperability and MIPS regulatory world. Underneath that, currently there's one measure, and that is provide patients with access to their health information. I would love to see added in there an attestation measure that organizations must provide the patient with education either on their organization page, how to access their health information, how to safeguard for privacy reasons. A lot of states have brought in, we've got the AB 352 in California, for example, and provide that information to the patient of what exactly can they access. Because I think if you have that information at the organization level, so I go to Stanford, you go to your primary care, you go to your organization, that is where the patient is going to first look at to see, how can I access my information? I want to see my lab results. I want to see my mammogram results. And that's where I think we will need to push for a change. And it would be, as I mentioned, an attestation measure maybe. And for everybody in the audience, an attestation measure means you have to build out what's specific in the requirements. It looks like on a QRD3 file, a check mark, but you do have to have proof that you went live within that reporting year with the specific requirements. So it's either screenshots or a report of some kind. So that's what I would love to see happen, because I do think, as I mentioned, that it will need to be regulatory required for to push the organizations to have that information available to the patients.
Yeah, and just to help everybody understand sort of the broader context, with the Consumer Engagement Workgroup, we're working on putting together a set of best practices, and Cathriona talked about this a bit, but putting together best practices and a toolkit for you, for the members, of how to best inform patients of what they have a right to access, beginning from the starting point of somebody at a point of crisis, somebody like I was in a position like I was in recently, as somebody who understands this stuff, who needed a prompt from friends, from people who actually wrote the rules, about what it is I needed to look for. How can we give that to the everyman and provide you, the members, with tools to be able to do that? In addition, our goal is to really get industry to do these things without the requirement for regulatory oversight. But the reality is that we do need regulators to step in more often than not, because not everybody in the industry is in this room. Not everybody in the industry is committed to doing things to make it easier for patients. And even if they want to do the right thing, they've got a long to-do list, and there are lots of other requirements and lots of other things they need to keep on top of. So, Holly, from a slightly different perspective, when you think about things from a QHIN, what are the challenges for you as a QHIN? MedAllies is one of the QHINs. What are the challenges for you and opportunities for getting patients, making it easier for patients, or decreasing that workload and helping patients who are faced with challenges in accessing their data?
Well, so the QHINs are conduits. We transport the data. We don't actually at MedAllies hold data. I mentioned that we are going to build to the specifications for data usability, which is why we're members of Taking Root. So I think that's one step in helping. But I also wanted to mention that this is one of the beautiful things about the applications that are being created for patient use. We work with two companies, Selfie and Citizen. And Devin, a call out to you because you've done some amazing work in Citizen.
Devin's getting major props on this panel, but she deserves them all.
I'll share a really quick story. My sister, many years ago, died of breast cancer. And she was a researcher, in fact, a PhD researcher, and she worked at Yale. And she was told she basically had 6 months to live with her cancer, and she said that's not long enough. She had young children, and she went on to be her own advocate, and she only could do that because she was such a great researcher. She had to go to a million different sites and get information from calling people, from extensive searches, and finally, she did such a great job that she went on to live 5 years after being told that her diagnosis was 6 months. And I think these applications, for example, look at Citizen, where it's for rare cancers, but if a patient goes on there, they're actually exposed to where treatment is provided, what studies are available, and they can really manage their care without being as sophisticated as my sister. And I think these are all critical things. When you look at Selfie, that's an application where patients can actually enter their outcome and consent, because I think there was a survey that 90% of patients with cancer want to share their data to improve outcomes. And so that site allows patients to not only enter their outcome or their information, but also to consent to share it for research purposes. So I think this is going to be an area where we do see so much of the education that you're looking for. I don't disagree that it should be mandated, but I do think we need to go beyond basic for people that really are trying to manage themselves.
I know we're almost out of time. I just want to add, I mean, that one thing that you find when you're in healthcare is the Dunning effect everywhere, right? Like the more you learn about something, the less you know about everything else. And it's true with consumer engagement. I mean, we've been talking about this for 45 or 50 minutes or however long we've been up here, and we didn't get to anything on accessibility issues. We didn't get to anything on, along those lines, language issues. There was a really interesting panel last week on patients that speak different languages, and are they more or less likely to use the portal or APIs and access their information. There are all these issues that go into this. And on top of that, we have issues where the patient is basically being tasked with being the runner of their information, right? Like to the panel earlier, if we can't even decide on what treatment is, then we're gonna have more and more cases of where the patient is being asked to get all their information because that's the easiest way to do it, and now it's outside the bounds of HIPAA, and now the patient can do whatever they want with it. But then that brings up data usability issues and access issues, and that there are all of these complications. And regulation is one way to get there. In some ways, it might be the best, but we're kind of in this cycle where so many things are being regulated. There's so many regulations that are coming out that you almost have to regulate to get it to the top of the list. But at the same time, you want to be careful on what you're regulating and make sure that you have a good solid framework. And I think the regulations work the best when you have a good solid framework and groundwork, and a lot of people are following to some extent, and you're trying to close the gaps instead of trying to get people to do everything from the beginning. So something like what consumer engagement is trying to do and create these best practices and trying to outline what needs to be done. I think a lot of those things could lead to future development, but I would just be, I guess, careful in trying to overregulate.
I completely agree. I mean, I think regulation can be a very effective but a very blunt instrument. So, which is why, in addition to developing the best practices in the toolkit, our next thing is to develop a pledge for Sequoia project members and beyond about adopting these best practices, which we're in the process of developing. And our objective is to make it easier on providers and EHR companies and people within the industry to do this, to give you the tools, to make it possible for you to do what you can do to empower patients so that they're not living in a time of urgent need without their information, that there aren't those facing those consequences. But that takes everybody focused on, not just developing the materials, which many of us in this room are doing, but also implementing those materials and adopting those materials and getting their peers in the industry to adopt those materials once developed. So we are out of time, but I want to say thank you so much to my fellow panelists, and thank you to each of you. Come join us.
Thank you, Anna.